Doctor, we are live now.
All right. Good evening, one and all. A warm welcome to all the panelists and speakers and audience. On behalf of UC and UC Medical Legal team, I welcome you all. We have gathered here again for another exciting session. So far, we have covered 27 topics, very important, pertinent topics related to medical legal aspects. A few important ones include consent, record keeping, indemnity insurance, telemedicine, cataract surgery related medical legal aspects, ROP, medical certificates, anti-VEGF related medical legal aspects, issues related to mass cataract surgeries, NMC guidelines for ophthalmologists, tackling assaults against doctors, medical legal aspects related to life surgery, criminal and civil responsibility of the hospitals, permission for eye hospitals, legal licensing, medical legal aspects related to biomedical waste, medical tourism, and sponsorship by the trade. We have gathered here for another interesting talk. The topic for today's talk is NABH Eye Care Standards Overview and 10 Steps for Implementation. For this session, we have our panelist. I would like to first start by introducing Dr. Anand Deshpande, sir, who is the director and eye surgeon at Guru Prasad Netra Rangnalaya at Aurangabad. Sir is also the chairman of the Indian Medical Legal Consulting Services Private Limited and also the chairman of the Medical Legal Committee of the AIOS. Sir is also the faculty of law and visiting professor to Symbiosis Law College, Pune, and also he is the faculty of Management Service Sciences, BAMU Aurangabad. Sir has written various books like Legal Aspects in Ophthalmology, to name a few. We welcome you, sir. Next up, I would like to introduce Dr. Manoj Mathur, sir, who is a senior consultant in glaucoma and comprehensive ophthalmology at Swaroop Eye Center, Hyderabad. Sir is also the present treasurer of the All India Ophthalmic Society and past advisor and president of the Telangana Ophthalmological Society and Hyderabad Ophthalmologists Association. He is the co-chair of the Health Insurance in the TPA Committee of AIOS and has been a member of the Medical Legal and Ethics Committee of AIOS in the past. Sir has been twice a member of Managing Committee of AIOS and also served as a member of the Advisory Board of IGO. We welcome you, sir. Next up is Dr. Prakash Marathe, sir. He is the consultant at the Netrayogi Eye Clinic, Pune. Sir has been the past president of the IMA Pune Maharashtra Ophthalmological Society and Pune Ophthalmological Society. He is also the past senior vice president of the IMA Maharashtra State. Sir is trustee of IMA Pune and Pune Ophthalmological Society and member of the Medical Legal Committee and of the All India Ophthalmic Society. He is also the recipient of various awards. To name a few, is the BOA Gold Medal Award in 2024, President's Appreciation Award in 2018 and 2022, President's Appreciation Award by AMA Maharashtra State for multiple years, President's Special Felicitation Award by IMA Maharashtra State for 2021. He is also the chairman of the Maharashtra IS MSICS chapter. So, as the joint organizing secretary of the World Conference of the IS MSICS 2019 conference. Also, sir has presented on various platforms and conducted various instruction courses. We welcome you, sir. Last, we have Dr. Sumit Khanduja, sir, who is an alumnus of RP Center, AIMS, New Delhi, and he's currently the professor and head of the Department of Ophthalmology at Kalpana Chawla Government Medical College and Hospital, Karnal, Haryana. Sir has been the NABH assessor since 2019 and principal assessor since 2022. So I welcome all the panelists for today's session. And for today's session, we have a very esteemed speaker, Dr. Nirmal, Professor Dr. Nirmal Frederick, sir, who is currently the Honorary General Secretary of the All India Ophthalmological Society, Director of the Medical Services Center for Sight Group, Director, Department of Ocular Oncology. No. Sorry. I'm sorry. There has been a
You
mistake, sir.
mixed with
That is
Santosh.
Santosh, right?
I'm sorry.
Good promotion. Good promotion. I thought he's secretary. That is probably Santosh Honavar. Good promotion.
Sorry.
How I wish without an election we can put out.
No, I was surprised and it was a good news for me.
Okay,
Sorry
don't
for
worry.
that, sir.
No issues. Just let.
Over to you.
We know
We
that
welcome.
Nirmal sir doesn't need any introduction. So Dipanshu, it's okay. We'll apologize to sir. Nirmal sir has been part of our various sessions, and we are really grateful that sir has taken time out from his busy schedule. And we all know that sir has a lot of experience when it comes to this topic of NABH. So over to you, Nirmal sir, for your presentation.
Before Dr. Nirmal sir starts, few words about Dr. Nirmal. I think he's past president of Tamil Nadu Ophthalmological Society and past president of IMA Tamil Nadu. That's what I remember. These are the major landmarks. And he's involved in various instruction courses and various talks. He has delivered at All India Ophthalmological Society conference and various state conferences as well as international platforms.
And as chairman of All India Ophthalmological Society Insurance and TPA Committee, recently has achieved a breakthrough with the Star Health Insurance, which we all know. We are really thankful to Dr. Nirmal for his excellent leadership in these areas and taking the issues forward and helping the IOS.
Thank you, everyone. And it's been an honor and privilege to be with the YOSI team once again, and to be sharing the chair with Dr. Deshpande, Dr. Mathur, and Dr. Prakash Marathe, and my young colleagues. It's been a real pleasure. And today's topic was he asked to cover NABH eye care standards and overview, and also give step-by-step approach for implementation. I'll just quickly, since it is a young Ophthal forum, I thought I'll give an overview of what accreditation standards are all about and how we can go about implementation. So let me divide this into two parts. One is the overview and then how to approach the accreditation. Anyway, these are my credentials, and I've been with NABH since 2007, and it's been a long journey. We learned a lot along this journey, and now apart from being the principal assessor, I'm also part of the accreditation committee to grant the accreditation to the member organizations. Been serving this board for the last 3 years. Right. So let me start with this question to all of you. So why accreditation is necessary for modern ophthalmic practice? So it's been in US, there is organization called Joint Commission International Accreditation. So this is actually was initiated by the American Academy of Physicians. So it was doctors peer group standardizing and helping their peer to implement quality standards. So over a period of time, so this structure got evolved, and now in the US and in the international arena, this is one of the topmost accrediting agency, Joint Commission International, or shortly known as JCI. So in India, so we felt the absence of such accrediting committee or accreditation agency, and then Quality Council of India, which is part of the Planning Commission came up with the idea of starting a healthcare accrediting part called as National Accreditation Board for Hospitals and Healthcare Providers. So in short, we call it as NABH. So you all know the top challenges in practice. Let us see how accreditation standards help in practice. And so these are the top challenges in practice. A newbie or a young ophthalmologist coming out of a top institution, armed with so many numbers of cataract surgery or eye surgery to his credit, and with so many fellowships, want to start a practice. So these are the challenges nowadays. So the healthcare regulations, there's so many regulations to start a practice. The second one is, however, how many degrees ever we get, the communication aspect is missing. We are scared to see the patient unless we are guided by our chief or some senior leaders. Infection control, the moment we see an endophthalmitis, our mind gets stop operating, or there are people who are scared about hearing this infection. And then auditing, again, exams are nothing new to us, but auditing is another important aspect in practice. Then how to manage the facility. So we all know how to tackle a eye surgery or emergency, but managing the facility comes with top challenges. The next important challenge is the managing our own people. So most difficult aspect in running a practice. And now a lot of medical legal challenges, you already covered those. And of course, as Dr. Mathur said, insurance is another new challenge in ophthalmic practice. So let's see how accreditation standards can help in managing these challenges. If you see that, why it is challenge to us? Because all these challenges have not been taught to us in medical college or postgraduate curriculum. That's why all these are difficult for us and stand as a wall in between us starting a practice. So let me give you an overview of how it will help. So the first and foremost is the regulation. And many of us are not aware of what exactly regulation, statutory requirements we require to start practice. And so if you see, most of the accreditation standards are part of Clinical Establishment Act or licensing norms. So if you already have a clinical establishment registration, many of the accreditation standards are already fulfilled. The second aspect related to outsourced services. Some of us have in-house facilities, but some has to be outsourced to an external agency. So for them, we need to have certain quality assurance system in place, and we call it as MOU or Memorandum of Understanding. All this have to be put in writing to safeguard ourselves. The second aspect is safety in our facilities. We all know about the structural component, how to build a hospital, and also equip with medical equipments. And most of us would have a wonderful architectural and aesthetic hospital. But our focus has to be on the critical systems. This is very, very important in day-to-day practice. So whether there is an emergency exit system, is there a fire system, and good electric system with the backup, water supply with alternative water supply, medical gas, how do we manage those things? And of course, communication system. In spite of having 4G and 5G, many breakups happen in our communication system. And then effective signboards. So patients want sufficient and effective signboards. So standards help us in getting those signboards in the proper perspective. Which signboard, whether it's a single language or bilingual, and whether it is international sign, all those things, the standards helps us to understand. So there's a lot of focus on signages, and this is also one of the assessment criteria. And we all deal with vulnerable patients. So many of our hospitals are not really friendly for the physically challenged, and we deal with visually challenged people. So we have to ensure that our toilets are friendly for the disabled people. We have good access to the emergency department, accessible to ambulance and wheelchair patients. And if visually challenged people come, we are railing to hold on to stairs or a ramp to approach our office or the hospital. So these are real important points we need to look forward. And then the third aspect is the patient safety and common. So these are common errors. So instead of right eye operating on the left eye and operating on the wrong part, wrong surgery. And of course, infection is a common thing. So this is one such instance. You can see that instead of operating on the left eye, the child was operated on the right eye. And apart from this safety, we also need to have safer facility for our men and machines. You need to have generators, backup, and we deal with a lot of computers and softwares. So you need to have appropriate power supply to them. And of course, our autoclave have to be backup. We need to have Class B autoclave for the safety of our equipment as well as FECO machines and similar machines. The third aspect is service quality. Right, very often we have this complaint management system in other service industry like airline or our own telephone departments. But in hospitals, this is rarely heard of. So we need to have a proper service assessment system in our hospitals, right from arrival to discharge, and of course payment, and we need to get the feedback. So this customer needs assessment is an important aspect of our service encounter with our patients. So we need to get feedback. There are so many ways of getting the feedback now. Of course, Google review is one such thing. We have to ensure, this also helps us to ensure the service quality. So feedback, so there are a lot of avenues now available, so you can focus on one of them. And the fourth aspect is focus on the staff. Human resources is the most important resource of any organization. So we need to not only have an induction training, but also on the job training. As doctors, we get a lot of opportunities to train ourselves and update amongst ourselves. But our staff lack this support. So we need to have training system to ensure our staff are equally trained as, and so this actually helps the staff morale and satisfaction. The fifth point is documentation. Most of us are very poor documenters, and this actually plays a major role in any auditing and assessment. So this is the documentation pyramid. We need to have proper records of all the activities we do. And this has to be in a standardized format for ease of working and getting the real results. And we also need to have standard operating procedures. All this have to be written and so the part of the quality manual, what we call it as Apex manual. And so basically, if you have all the system in proper documentation, other than the service part, the accounting and finance part, then it will be easy for us to tackle the insurance aspect as well. The sixth element is auditing. So auditing is part and parcel of accreditation. We can have internal auditing as well as external peer assessment or auditing. So this part actually not only there has to be an internal audit mechanism to ensure all our processes are followed as per the standards. And as well as before the external audit team comes, the internal audit team can identify the errors, identify the challenges, and help to integrate the standard within our hospitals. To help in auditing, we have certain indicators. So these indicators are called quality control indicators, or some hospitals call them as KPI, key performance indicators. So what is the time taken for seeing the patients, and what is the infection rate in our hospitals? What is the error rate in our opticals? So these are some kind of indicators that gives an overview of our hospital performance in terms of numbers. And so auditing also helps to improve and reduce medico-legal problems, so which you would have already heard of. And so if you do follow all these standards, we can reduce the regulatory hassles as well as the medico-legal challenges. The seventh important aspect or practice challenge is branding. So many of us know how to run a practice, but how to take it to the next level. For that, branding and marketing is essential. And accreditation serves as a wonderful branding tool. That's why most of the organization, if you see on the front board, there'll be a lot of logos. Among the hospitals, the most important branding element or branding logo has been NABH. So, and they are proud saying that our hospital is NABH accredited. That's because this also helps in benchmarking to select the best hospital in India. Very often you see newspapers projecting as these are the best hospital in this region, all over the country like that. And most of the parameters are based on NABH standards and key performance indicators. Right. And so now NABH is also reaching the public in terms of grading the hospital and helping the public to choose the right hospital. Patients now prefer internet to find the hospital, and this acts as a wonderful branding tool. And the last aspect is, as youngsters, so you've all been taught about ophthalmology, the clinical methods, and also to a certain way management of various departments. But putting everything together, building the team, solving the day-to-day problems, and also showing continuous improvement, and also managing the key performance measures, all this require certain way of growth, certain way of management skills, and that is called as leadership skills. And these standards really helps the youngsters to understand what is important for managing the hospital and practice, and also help in understanding the key aspect in managing the practice. So accreditation standards are like guidebook for medical professionals and big leaders. So in an overview, standards teaches us skills not taught in medical colleges and help us to keep pace with the practice-related issues like regulatory compliance, the documentary requirements, and reduce complaint, waste, and defect reduction and elimination of rework, and more importantly, patient satisfaction, employee satisfaction, and management satisfactions. So very often youngsters are familiar with so whatever any complex job, they ask whether there is an app for that, right? So in healthcare, this app is the accreditation app, so which puts together whatever required for practice in 10 chapters and various standards. So accreditation is also a wonderful management tool and app for putting across many things required for our practices. So you can always say that we already have our own system. Why should we go for accreditation? So we all know that markets don't accept our own system. They want a third-party system to brand our practices. And that is where NABH comes into the picture. So the accreditation has been a win-win for all stakeholders, not only patients, families, staff, board members, and the hospital directors. And over a period of time, maybe initially there is pain, but once you maintain the accreditation cycle over 1 or 2 cycles, you not only gain in many ways by maintaining the accreditation with better outcomes, increase efficiency, enhance quality and safety, and reduce risk for the patients. So this is just an overview of the accreditation standards. I have not gone into the deep aspect of the various chapters and standards. And let's see how we can enter this journey, because we need to assess whether your practice is ready for accreditation. So this is how we did a survey of 176 doctors about implementing quality standards. And most of them are in the preparatory stage. So this is among the young ophthalmologists. So if you see that 50% want to go for accreditation and 10 to 15 already assessed or accredited. So once you decide to go for accreditation, so it is indeed a big step. So it needs certain important aspect to understand other than these things I have listed so far. So how to start, when to start, where to start, this is a question. So I just put across this in easy steps, right? So you need to start some point of time. So the journey of 1,000 miles begin with 1 step, and you need to buy these standards book and guidebook. So now it is not, you don't even need to buy, because the main standard is available free for download. All you have to do is register your name in NABH website and download the first edition ICAS standards or whatever standard is applicable to it. So all the standards are now available in the NABH website free of cost. Only the guidebook you need to pay and get. So choose what is the relevant standard for you. And few years back, we also wrote a CME series for accreditation of eye centers. That will be a good resource for you to start with. And this is again available in our AOS website. And the best resources, you can go through this NABH website. Most of the information about NABH ICAR standard is listed here. So you can have a preview of NABH website and all the resource documents there. There are a lot of online and on-site courses available. So many organizations are there conducting various courses. You can attend one of them to get important information about this. So once you get this resources, you need to read. Yes?
Can someone please mute Dr. Amit? Sorry for the disturbance.
Okay. Maybe another 5-6 minutes I'll take. Right. So
you
need
have
to,
all the time. You can take your time.
Yeah. Thank you, Aarti. So this is a bit, the standards are worded in a legal format. But if you go through the guidebooks and the our CME series, it is written in a very lucid, simple language, and the 10 chapters are easily dealt with, and also gives an approach to implementing those chapters and standards in your hospital. So the ideal standard for eye care organization is the ECO standard. This has 305 objective elements and 10 chapters. Right. The second step is forming a quality team. So each hospital need to appoint a quality coordinator who will deal with your staff, coordinate the work among your staff, as well as coordinate this assessment with the NABH secretariat. So this quality coordinator ideally should be a senior person who has understanding of the hospital, as well as has good working relationship with all the hospital staff. So basically, there is a job description for them. They need to take this as a full-time job and coordinate. And important to have a core team for implementation. There are various teams necessary, but important is the top 3 committees: quality committee, safety committee, and CPR committee, as well as infection control committee. These are the important committees in an eye hospital. But of course, the team and the committees depends on the size of your organization and the number of departments you have. And you also need to have some small expert committees to monitor and report to the management and evaluate. So this is basically a cycle. You have to keep improving and monitor the improvement, then evaluate how it is being practiced, and then report to the management and the quality team. So there is a 8-step implementation process. To start with, you need to find the gap. What are all the standards required to be implemented, and what is existing in the hospital? So this is called as gap analysis. And then we have to train the people about the standards. So basically, this 10 chapters, most of the staff may not be aware of these chapters and the requirement. You need to have frequent interaction and training. So it's not only structured training, you can also have a chat with the important member of your staff. Then you need to prepare the standard operating procedures and policies as per NABH requirement. And this is the important 3rd step. And then we need to train our staff how to write the standard operating procedure, how to implement them in the various areas of the hospital, and then have an audit. So this is the 8-step process. And let me take you through the 8-step process. How to conduct a gap analysis. So basically, there is a gap in the hospital between what is required for the NABH standards and what is really available. So this may be infrastructure gap, this may be process related gap, it may be human resources related gap, or technology related gap. So we need to identify those weak and strong areas. And basically, in any functioning hospital, so almost 60 to 70% will be available. They may be partially met. So 10 to 20% will already be there. So what is important is you have to identify what is partially there and what is not really there, and then start implementing them. And then, as I said, training is very, very important. Training about NABH standards as well as the certain requirements for implementation. And everybody has to be trained, not only administrative staff or paramedical staff. The doctors and nurses also have to be trained. And the first part, the doctors are the important people to be trained in these kind of standards integration. Step 3 is documentation. This has to be written as per what you are doing in your facility. And so very important to have documentation. So this is the ideal structuring of the documentation. You need to have an introductory document about your hospital, and then how the hospital is fulfilling the NABH standards, and medical and non-medical documentation, and the standard operating procedures, work instructions for your staff, how they have to handle the equipment, how they have to handle the reception, discharge process, everything. So these are based on certain formats. And all of them, you need to have certain references. You can't write your own document and say this is the best. So this has to be based on the references. So this is a way of preparing a manual. Since all of us have an infection control manual, I'll take that chapter to tell you something about how to write a manual. So basically, contents of infection control manual. So you need to introduce your eye center and also the infection control program in your facility. So if it is a small single operation theater and small facility, so all it needs is few pages, say 8 to 10 pages. Whereas in a large multi-speciality eye hospital would require a lot of SOPs and documentation. You need to have an infection control team, ideally a doctor, a nurse, and the OT staff, and of course somebody trained in infection control, like a staff nurse or an administrator who undergone a training in infection control. Then each member's responsibility have to be written. What is their role in infection control, whether it's supervisory role or implementation role. And then what is the goal is to have zero infection rate. An objective, how we are going to achieve that zero infection is important. And how your staff have to perform hand hygiene. Of course, all these are international guidelines available. You need to train your staff how to put a mask, how to autoclave. So all this standard operating procedure have to be written in the manual. You also need to have antibiotic policy and certain things based on biomedical wastage and housekeeping and regular disinfection of your facilities. So all this put together is called as infection control manual. So this manual have to be written for all the 10 chapters. Then how do we implement? So there are patient care standards, there are organization channels. If you see that 10 chapters in the NABH standard, the first 5 are related to patient care and the next 5 are related to the hospital management. So you have to ensure the doctors, nurses, and paramedics understand these 2 types of standards. And many of them are the patient care standards are related to how do you assess the patients. So initial assessment, reassessment, and then what is the clinical protocol and what all have to be documented, whether it is manual documentation or EMR, all those things have to be listed. And these are organizational standards, patient rights, how your staff need to do autoclaving, sterilization of OP, all those things are part of the hospital standards. And then internal audit. So once you start implementing, some of your people can become internal auditors. So they can go to other areas and audit and see what are all implemented fully and whether there are any gaps in the implementation. So this is called self-evaluation or internal assessment. Some people call it as internal audit. Some hospitals call it as internal assessment. And basically all quality management system needs internal assessment. And then the new system has to be integrated in day-to-day functioning over a period of time, ideally 3 months or 6 months, depending on the size of your organization and the scope of your services. And this has to be continuous. So internal audit has to be done every 3 months or 4 months, depending on the size of your organizations. And all these audit findings have to be documented. And based on the audit findings, so we have to keep training our staff to correct their ways and do the activities in a proper way as per your standard operating procedure. So this is the implementation. So basically, there will be few challenges in implementing quality in any eye hospital. So basically, there might be an equipment gap. So with escalating cost, all the hospitals may not have the latest machines or the equipments to match the standards need. So in that case, you can go for outsourcing. And you also need to find out any infrastructural deficiency in the hospital. For example, a lift or ramp may be needed for vulnerable patients. And for OPD or IPD, if there are any emergency requirement like crash cart or Boyle's apparatus or a Class B autoclave, all those things have to be listed and see what all you can get during the implementation. And some staff are mandatory, like having a qualified nursing staff, or if you are running a pharmacy, qualified pharmacist. So you need to assess the shortage of healthcare staff and try to fill that gap. And training is a continuous part. So the training, there are certain mandatory training, there are certain important training for a particular group of staff. All those things have to be done. And licensing is another important aspect. You have to fulfill the basic licensing requirement for NABH. So step by step, all these things have to be integrated. So basically, the do's is we need to have a plan. You need to have a quality coordinator and a good team. Have all the important licenses in place. Then training is, there are 3 types of training. One is mandatory training for NABH implementation. And the second one is essential training. For example, the nursing staff in the OT have to undergo infection control training. And all the staff have to undergo the code red or code blue. This is fire requirement norms. And then there are certain preferable training. So the quality coordinator need to undergo NABH implementation course or such a course which teaches about implementation. Then internal audit and self-assessment is an important process. And once you find the deficiencies, you have to close the deficiencies effectively to ensure that standards are integrated. So far I've told you about the do's in accreditation, and a couple of points on don'ts in accreditation. It's also important step. The first don't is don't copy the manual. So be original, don't plagiarize. Very, very important that you write what you do in your hospital. It's very, very simple. Just jot, even if it is 2-page document, if it is written by you and your team, that is the best document, and so never copy. The second thing is the standard operating procedure has to be written by you and your team, and ensure the workflow is same as that of what you write in the standard operating procedure. Never copy from internet or get from the other consultants or other hospital document, because each hospital is they are unique in their own way. So never copy from your competitor or from the internet. The next important thing is use the root cause analysis to improve yourself, not be a fault finding mission. So there's a lot of attrition in during the implementation, because once you start questioning the staff, there might be some blame game. So it should not be a blame game. It should be for improvement, and use the root cause analysis to improve your processes, and do not make it as a fault finding mission. And this is very important. Don't consider NABH or assessor as your enemy. So treat them as your colleagues to help you in the accreditation journey. So these are the important don'ts. Do not copy the documents, manual or SOPs, and do not take errors easily. So identify the root cause, act on it. Corrective action and preventive action is very, very important, because reducing the risk is very important in healthcare now, particularly related to safety and maintenance. And don't lose your CCC. These three C's are important, like your CCC in CATAC: consent, communication, and counseling. And then important is you have to document these 3C by good documentation. And don't focus only on the certificate for insurance and financial benefits. They are byproducts of the quality system. Once your quality improves, automatically the certification and empowerment will follow. And it is a bit arduous process. Don't quit in between. Enjoy the learning and journey of accreditation. So ensure all these standards are implemented and integrated to the day-to-day functioning of your eye clinic or whatever you call it, and apply and be ready for assessment. So there is a timeline for entry level or eye care standards. So generally it is 3 months. So once you apply, there will be a document verification in the NABH secretariat, and then the assessment team will be, a note will be sent to you, and you need to prepare for the assessment day. And so they might give you some non-conformance report, and you have to close those non-conformances diligently within a time frame. And and then support the close all the non-conformances and achieve the mark of excellence. So these are the frequently asked questions. I have a good practice. What value do I gain because of this logo? And it is usually for corporates and medical tourism providers. Why should a small private practitioner or young ophthalmologist go through this rigmarole? It is so difficult, not practical, and costly. Why do it now? I can do it after 5 years or 10 years. So these are the common misperceptions. But in reality, accreditation is a very good branding, marketing, and management tool. It's cost effective over a period of time. It improves all the business aspect and image of your eye care organization, enhances quality and reduces the risk. And most importantly, it also reduces the medical legal risk. So basically, NABH journey is a continuous quality improvement. So it's you need to work for it and make it a reality. And more importantly, you need to enjoy the process. So enjoy, do what you enjoy, and enjoy what you do. Automatically, you can heal this world, make it a better place for you, for us, and for all of us. So thank you so much for your kind attention. And thank you for the opportunity, YOSI team. Been a pleasure with you.
Thank you very much, sir.
Thank
That was a very detailed talk, and you very well simplified in a stepwise manner for the better understanding of the young ophthalmologist. It was very elaborative as well. I would like to apologize for my earlier technical mistake while I was introducing you, sir. So I would like to once
No
formally
issues.
introduce you. Sir has for today's talk we had an eminent speaker, Dr. Nirmal Frederick, sir, who has been the president of TNOA in the year 2023 to 2024. Sir is currently the chairman of the insurance committee of the All India Ophthalmological Society. And also, sir has been the advisor of various ophthalmic journals, to name a few, are IGO, JIMA, TNOA. Sir, has been the principal assessor of the NABH and healthcare providers for Quality Council of India and chairman of the NABH Eye Care Standards. Sir also is the accreditation committee member of the NABH. Sir has been the member of managing committee of AIOS from over a large period of time, and also the president of the Tambaram Ophthalmological Society. And formerly, sir has been the assistant professor of ophthalmology at Madras Medical College and immediate past president of the TNOA. And sir has been awarded with the AIOS Preeti Natarajan Award for Best Eye Hospital Administration in the year 2017. Thank you. Welcome you, sir, and thank you. And apologize for the mistake. So now I would like to open the discussion for our panelists. If I would like to introduce, call Dr. Anand Deshpande, sir, to share his words of wisdom on this topic.
To speak about this, he has excellently given the talk, and he has covered all aspects of the NABH and how it helps. That is also is shown. To summarize a little bit in different way, I will say NABH is required for a better care of the patients. That is true, and he has explained it a lot. Secondly, what is more important is that the new Consumer Protection Act 19 has given some more things that patient can lodge for a complaint against the doctor, and that is the quality of services. So there is no benchmark where you can say that my quality is good or my quality is this, that, and that. So you cannot prove it in the court. But NABH accreditation, if it is shown to the court understands that this is a standard hospital and definitely has a weightage for that, and the considerations are totally changed in the minds of the judges. So having accreditation in a medical legal case is a very important thing, because whatever happens in an accredited hospital is a standard and nothing will go wrong. That is the concept which judges takes with them, and that helps in the decision definitely. So that way, another thing is that the Consumer Protection Act 19 has given the responsibility of manufacturing defect. That is a defect. Manufacturing defect is only that services are not to having some defective services. That means your procedures are wrong, your surgical procedures are wrong, or somewhere there is a defect and which caused the damage to the patient. And to prove that there is no defect, accreditation is the best way that if hospital is accreditation, that it shows that there was no defect in manufacturing, that is a product defect is covered. So these two important things of the Consumer Protection Acts, which are added newly, are covered because of the NABH. If it is there, the doctor is, our hospital is saved a lot. Thirdly, it is a very important thing in marketing, particularly in medical tourism. People see whether the hospital is NABH accredited, and that only they are taking. Another thing is people are going on Google and saying which hospital is accredited, and that affects a lot. And so many companies are also want to get attached to the hospitals which are accredited. So from that point of marketing point of view also, NABH is very important. All these aspects he has covered very nicely and very strongly. So there is nothing he has left in the NABH.
Thank you, sir. Now I would like to ask Manoj Mathur sir to please share a few of
Yeah.
his comments.
After we have heard a wonderful exposition from the expert in the country, Dr. Nirmal Frederick, for this NABH things. The first question asked is why NABH? NABH is basically not to get a certification or accreditation to show or to do this. If you want to do something good, the first step is your intention. This thing, as he rightly said, you have to write your own SOP. Or you have to document your own adversities that you face, your difficulties that you face. The issue that you encounter in your setup should be properly documented, and also document how you have overcome that adversity in your setup. Those things are very, very important when the NABH assessor comes to inspect your place. So basically, you must understand that it is not to just get brownie points or to get some certificates or some affiliations, but it is to improve yourself. What best service, what best care that you can provide to your patients. So basically, Nirmal sir has condensed, if I must say, 10 chapters into 10 sentences, to be honest. NABH course goes on, and there are even a day-long courses for NABH, but he has nicely summarized in just 35 minutes. So I really congratulate Dr. Nirmal sir, and as Dr. Deshpande sir said, even in the medico-legal things, even to get an insurance empanelment, you need to have an NABH, because you have to justify certain standards for your eye care center to be empaneled with respect and with the agencies and all. So even medico-legally, it is very important. It's not that when you are starting the eye center, straight away think about NABH, do good for your center, write your own SOP, so move step by step, and NABH automatically comes to you. So NABH should come to you as a byproduct, but yes, with lot of effort, you know what efforts to put in. NABH should come to you as a byproduct, as a way of you giving proper service and proper eye care service to your patients.
Thank you, sir. So now I would request Dr. Marathe sir to give his expert opinion on this.
Thank you, Dr. Dipanshu. I must congratulate YOSI for taking this topic. This is a very important topic, and the master in the country has already said is Dr. Nirmal Frederick. I think he knows everything about NABH. He knows he is the main coordinator. He does NABH accreditation. He helps so many people in the country. I think for youngsters, I think they should move forward in their practice. It is not the basic practice. Nowadays, with the equipments, with the procedures, with the scientific knowledge, you have to move forward. And NABH is the thing which takes you forward in all your procedures, like surgical procedures and consultations and each and everything. I've got two queries in my mind, and I like Dr. Nirmal to answer, because state health is the state subject. Now, if you consider Clinical Establishment Act was passed centrally, then union territories by default they have accepted. Few of the states also have accepted Clinical Establishment Act of their own version of that state. Now in Maharashtra, till date, Clinical Establishment Act is not implemented. But we have given Maharashtra version of Clinical Establishment Act to the government. Still here, it's Bombay Nursing Home Act. Now, as health is the state subject, is there any difference in various states in relation to NABH? That is my first question. Dr. Nirmal?
Okay. Yes, sir. As I rightly said, though Clinical Establishment Act is a central act, various states have adopted it in a different way. For example, in Tamil Nadu, one of the person who drafted this part of the committee, there were a few lenient approach towards the Clinical Establishment Act. And we also added a daycare establishment part in that for clinics as well as daycare centers. Now, so this happened 10 years back. Now there are a lot of daycare establishment, not only Ofstal, ENT, dialysis center, everything has become daycare, infertility centers. So it was a good forward-thinking aspect. And states have adopted their version. See, even yesterday there was an announcement that in Bihar, there is no need for clinical establishment for small nursing homes, less than 50 beds. And similarly, there are various state variations. If we see the CEA itself, a lot of variation among the states. So in fact, for a country like this, we need to have certain variations because state-specific approach is essential. And for ophthalmology, if it is excluded, well and good. As long as it is only registration of facilities, there's no issues. But unfortunately, slowly license Raj is keeping it, right? So the government or the district establishment want to control the hospitals, not only the facilities, but also the activities, also the frequent licensing requirement. And more importantly, they also want to control the cost. So this is where problems starting in this Clinical Establishment Act. And also there are a lot of variation with reference to the time period for each licenses. In some states, it is every 3 years or every 5 years. In some states, it's for perpetual. That means once you register, the license is there forever. So a lot of variations are there. So that actually makes things difficult. So ideally, for encouraging small hospitals, I would really request the government to have a commonality in the licensing department. So too many licenses, actually, it's not good for the small healthcare organization, particularly eye hospital sector.
In our country, in Maharashtra state, I think we still have that Bombay Nursing Home Act.
Yeah.
And in Bombay Nursing Home Act, there are only two categories, a clinic and the hospital, where nursing home is also covered. So there is no third entity of daycare center. So we are fighting with the government and make special category of daycare, which still is not permitted by the government. But with the new Maharashtra version of Clinical Establishment Act from IMA platform, we have suggested them to have daycare center. So my next question is
that is a way to go, because the next 5 years, many specialties would come as short stay hospitals or daycare centers. So that will actually help the growth of industry.
Yeah. Sir, my next question is...
I have one small query. Is entry-level NABH enough for eye care centers, or do we need to mandatorily work upon?
Entry level is a step, sir, to get into the accreditation journey. So it has 10 chapters. The number of standards and objective elements is limited. And ideally, any quality journey, the hospital has to progress over a period of time. So from entry level to eye care standards, and from first accreditation to re-accreditation, there is a quality journey and progress involved. So ideally, we want every organization to go through the entry level and then go to on stages progressive to get into the accreditation bandwagon.
My next question is, probably it is a drawback of NABH. Most of the people feel that most of the clinics and hospitals, they are recognized by the name of the doctor, the qualification, the experience, and the name and fame and everything. So people come to that hospital and that clinic by the name of the doctor. But while doing the NABH accreditation, when it is a corporate hospital, big hospital, the compulsion is not there that the owner of the hospital should be the doctor. It may be non-doctor who is the owner. And while assessing with NABH, I think doctors' credentials are not that way important for NABH accreditation. What are your views, sir?
Okay, I do agree there is leverage for non-medical people to start hospitals, establish hospital, and run or manage the hospitals. So that is a larger policy view of the government. We can't go into this. Yes, there is a good leverage for doctor-run institutions, at least in the small hospital segment. The next one is about the credentials, right? So the credentialing and privileging of manpower is common for nurses, all doctors, including the owner or proprietor of the institution. So it's it is there in privileging and credentialing about the doctors, right from the chief doctor to all the specialists and the medical personnel involved. So it is there in the HR standard. It is common for all. And now there is also paramedical council coming for the optometrists. So previously there was no council for the optometrists. So now it is being established in all the states, paramedical council or allied health professional council to integrate all these non-nursing staff into the healthcare. So all the physiotherapists, optometrists, the mid-level ophthalmic personnel, paramedical ophthalmic assistant, all those things will come under this paramedical council. So that will actually help to standardize the educational requirement, the syllabus, and also their training part. So which will have over a period of time.
Actually speaking, the hospitals can be divided as a corporate hospital, trust hospital, cooperative hospital, or a solo hospital. As previously, solo was possible. But as there is a great investment is increasing day by day, and equipmentizations and facilities and all that, it is not for beyond the concept of the solo practice. The corporates have introduced themselves in the practice, and if they are not doctor, it doesn't matter. Credential goes with the good doctors that they are having. So if the doctors are good of that for that hospital, definitely the hospital gets the credential. But still, standardization is different thing rather than the clinical things. Actually speaking, the clinical results or the clinical steps are not modified, not suggested by NABH. They are suggested all other things rather than the actually doctor what he is doing. So that portion, clinical portion, is little bit left by the NABH on the doctors itself. And so it goes with the credentials of the doctors.
Thank you. Thank you, Nirmal sir. Thank you, Deshpande sir.
Thank you, Marathi sir, for putting out those important questions. Now, I would like to invite Sumit sir for his expert opinion. I have a question for you, sir. So, since you have been NABH assessors over this so many years, so what are the common mistakes you find which new hospitals make, or what are the major non-compliances which you have come across whenever a new hospital applies for NABH accreditation?
So Dipanshu, thank you for the kind invitation. So sir, I'd like to just make a few comments about from Dr. Marathe's talk. And first of all, my salutations to Nirmal sir. He's been my inspiration into NABH. So the first thing is that you should learn to recognize that NABH, that guidebook, it is a mini hospital management program. Okay, it's a consolidated hospital management booklet. And being a great clinician does not equate into being a great hospital or a great hospital manager. Okay, so like sir said that, what about the degree or credentials of the doctors? So maybe there's a doctor who has got who has been a topper in his days, but is a bad manager. Okay, or does not know. So at least the NABH guidebook makes it easy for you if you are able to, if you read the guidebook point by point, you're able to understand and implement this small hospital administration program in your practice, and it will definitely help you. Then regarding the Clinical Establishment Act, one sir said because of the different guidelines in the state. So one of the objective element of NABH is that you have to fulfill all the requirements of the law of the land, right? So coming to the common mistakes that I see is that, see, because of most of the hospitals are able to fulfill most of the requirements, surprisingly, the most common mistakes come in the most basic parts. That is, documentation part. Still, the biggest problem I find, even in the best of the corporates or the biggest of the brand names, is, the signing of consent forms, signing of, putting the SNDT in format. That is, the signature, name, date, and time. The third issue that I find is with the ability of not being able to do the clinical audits properly. And, in spite of the AIOS having released the guidebook by Nirmal Frederick sir, still, I would request that most people should go, and read that book and inculcate that practice of implementing, clinical audits. So these are some of my observations, sir.
Thank you. Thank you. We have a question in the chat box from Dr. Deepika Kadam that as per COP, that is care of patient point 8, an anesthetist usually conducts the pre-anesthetic assessment for operated patient. But can this be the permission, this privilege can be given to ophthalmologists to perform this assessment for patients undergoing topical anesthesia, surgery under topical anesthesia?
So, sir, I'd like to answer this, that understand one thing, that simple, uncomplicated surgery does not translate into simple, uncomplicated anesthesia. You know that even if there is a topical, you have taken up or decided a patient for topical surgery, there is always a chance that he may be converted into peribulbar block. Number two, there is a very staunch possibility of an oculodepressor reflex. And many a times, without a pre-anesthetic checkup, patients have missed people's ECGs. They have shown changes of ischemic heart disease, which actually got accentuated by using a lignocaine with adrenaline, and they landed up with complications. So as a matter of policy, I propagate that no matter whether you're doing a surgery in topical anesthesia, peribulbar anesthesia, get a PAC checkup done, get a ECG done, and let the patient be seen by a specialist in his field. So this is my submission on
Sir,
that.
how practical is that?
Well said,
really speaking.
Dr. Sumit. I agree with each of his observation, because patient, the important policy or guideline in the entire medical field is do no harm. Right? When you are doing a procedure, so you have to concentrate on that procedure as a surgeon, and your team can concentrate on the other aspect. But here, the anesthesia is a privileged assessment, has to be done only by the qualified individual. So, however good we are in medicine or the general assessment of the patient, that we can miss it. And it is also a medico-legal nightmare, particularly if there is oculocardiac risk. So, or a patient, any patient, most of us are operating on vulnerable age group. So we cannot assess all the systemic conditions of the hospital, of the patient. So we have to acknowledge our limitations. So even though we want to reduce the cost for the patient, we are taking a huge medico-legal risk. And we are not privileged to do assessment beyond ophthalmic assessment. So this we have to learn to understand the legal requirements of our qualification. Even though we are basic MBBS doctors, we can do an initial assessment. We can do an overall risk assessment and stratification. But ideal is to get an anesthetic assessment in many of our high-risk patients.
Sir, I have a question. So does this mean like even
I
in
think,
practice?
Dr. Kaushik, sorry for the interruption. I think Anand sir want to comment something, and then we'll take up your question.
Ideally, the law doesn't mandate for the checkup of the anesthetist or a presence of the anesthetist. But if that is not there, then the judges always see that you are negligent because you are concentrating, as Dr. Nirmal said, on the patient for your surgery. If something happens, whether you will leave the surgery and concentrate on the patient or whether you are not, you cannot do that. Secondly, you are not sufficient to tackle the emergencies that can happen. If sometimes if the respiration stops, you cannot put the tube. If something happens, heart stops, you cannot do the cardiac massage, or you cannot give the defibrillators and all that things. So it is not a mandatory thing mentioned in the law. The judges expect, the law expects that there should be a second person who is either a good physician, or a better than that is the anesthetist. And for that, anesthetist checkup is very important. Physician's checkup is very important. Unless ECG is taken and everything is done, you cannot say that this patient is not having anything. Even the anesthetist cannot take the ECG on the place where he has gone. So previous examination of the patient is very important, and that is considered as you are taking the care of the patient by the law.
So, sir, I think it goes, it goes very logically as well. And not only just, we should say that it is written in any guidebook or what, that it has been a medical teaching for all of us that the person who is monitoring the patient perioperatively and the patient who is doing the surgery, they should be different. So had it been you yourself who had been undergoing the surgery, it goes without saying that one person cannot perform two things, prudently, doing a perioperative monitoring as well as doing the surgery yourself. So that is the point, sir.
So I have a question.
In short, I will say that pre-operative physician's fitness and at the time of surgery, standby anesthetist.
That is the expectation of the law.
Dr. Kaushik, you have a question?
Sir, actually, I wanted to know, like, what are the minimum prerequisites before we operate a patient for cataract surgery? And also, like, does that mean that even if I have a private setup and I am only operating surgeon, I need to do pre-anesthetic checkup with an anesthetist for all the cataract surgery patients? So is it required?
You see, the ECO standards do not define you whether you're a solo hospital or you are a big corporate chain. It just says that the flow is that any patient who's undergoing an eye surgery, irrespective of the indication of surgery, irrespective of the diagnosis, receives a pre-anesthetic checkup as deemed by any anesthesiologist, okay, receives immediate pre-anesthesia checkup, receives perioperative monitoring, and a post-anesthesia, again monitoring before he is sent back into the recovery. This is irrespective of the type of anesthesia used. If you read again into the book, that it says explicitly that even if a patient is undergoing a surgery under topical anesthesia, once during the surgery, you have to document the vitals of the patient. It's all written there. And it is not diagnosis specific, that whether it is a cataract surgery of a grade 1 cataract or a giant retinal tear surgery. It is not specific to any size of the institute, any turnover of the institute. So a patient, whether in a big hospital or small, has to receive the same quality of care to be accredited by this agency. That is the concept.
And sir,
and that irrespective of rural, suburban, or that is also important, because a life is a life irrespective of where the patient is treated.
So the concept is whether it is ASGI institute or it is a small hospital in any rural part of Haryana, if it is NABH accredited, they will offer the same standard of care.
There is one practical difficulty in rural areas where there is only one anesthetist available in that particular place. There are so many gynecologists and surgeons, and the anesthetist is busy. So it is not possible for ophthalmologists to bring or to call that anesthetist as standby. So this is the practical situation in most of the remote places in the country. So what is the view in that case, sir? Sumit, sir.
Sir, the point is that there are practical difficulties. But NABH is not enforcing anything upon you. It says that these are our criteria of a safe surgical setup, not only in terms of equipment, but also in terms of flow of work. To follow it or not follow it is in our hands. I can absolutely understand that there are many places where doctors are settling in. There is only one, and most of the tier 2 cities probably had the same scenario 30 years back. But I think, sir, with over time, with so many people are coming in, and moving out of metros, it won't be a difficulty in the future.
Okay.
The second choice is that if the anesthetist is not there, so physician can be a standby.
Yeah.
Because there is the aim is that there should be immediate medical aid available apart from the surgeon.
Yes.
And
So I
that
think
is expected by the law.
Yeah, the soul of the service is that in case there is a perioperative issue and a cardiac issue or anything, there should be a physician who is able to salvage the patient systemically. That is the soul of the service, sir.
Okay.
Nirmal sir, I have a question for you. So we know that NABH is very important for a very successful practice and to safeguard ourselves. So supposingly a young ophthalmologist is starting a practice. So do you recommend that it should be aim to build up a hospital as per the NABH standard to start it with? Does it involve the additional stress or let's say financial burden to a young ophthalmologist? Or when do you recommend that in the practice, when should we think about doing NABH accreditation?
Okay, so I would suggest the young ophthalmologist to build a statutorily compliant eye care facility, right? So NABH doesn't prescribe the statutory compliances. The compliances are given by the Government of India as per public safety norms under the National Building Code. So NABH is not really prescriptive. As Sumit said, we look at the important licenses and statutory requirements and not go into the details of the construction or the size of the facility. But ideally, when you are starting a practice, always better to follow the law of the land and to ensure your own investment does not go or fall into any conflict with the law of the land. So always get a proper building approval as per the zoning of your area of practice or location. Second, ensure you get a properly constructed building and get a completion certificate after the building is done. And then get all the operational licenses. The important operational licenses in our country are Fire and OC, the Pollution Control Board Biomedical Wastage license, and if you are building a pharmacy license. So these are bare minimum licenses required, and your building or practice has to comply with that.
Sure.
So starting a practice, investing so much and not complying with the law of the land, it always is a difficult issue.
Aarti ma'am, I don't know you are at what level in the practice, but if you actually ever go and break into the cost of the practice, then NABH doesn't really add so much of the cost of the practice, except for a modular OT that you need. If you go into look into the statutory guidelines that are that have come for the doctors, the land I see as the biggest investment currently. Maybe Kaushik is into a corporate chain. He would be knowing that the cost of buying a land or leasing a land is probably the biggest investment that you have to currently make in a practice. NABH, except for one statutory thing, that is an OT that has got your zoning practices, a CSSD, and an AHU system, doesn't add much to the cost of investment. Secondly, the workflow, as I said, that is, implementing a culture of audit, documentation. So these don't come at an additional cost. It comes at creating at the cost of an additional habit. I don't think that, ma'am, putting your signatures with name, date, and time or having engaging a person to audit your records. So it can happen that if you and your friend are trained in NABH standards, you can visit each other's hospitals and audit their records. That is the place where doctors actually need to come together and work. For example, if you are 3 young doctors in a city and you decide to open up independent practices, which is not the best decision. So, but you can be auditors for each other, right?
Correct.
So I don't think NABH actually adds a very major cost to your practice. It is the land and getting the statutory licenses. As sir said, because of the license Raj, you go and open the Ayushman HEM portal, you will come to know how many statutory licenses the government has imposed on you, even for getting an Ayushman panel.
In fact, in NABH ICAS standard, we have reduced the requirement for mandatory licenses. So only the 4 licenses, that is Clinical Establishment Act, Fire NOC, or a third party. So even there is a leverage that if you are not compliant or unable to get a fire NOC, you can get a third party fire verification system and report. That is more than enough. Then biomedical wastage is again part of Clinical Establishment Act, and even zoning, as Dr. Sumit said, it is part of Clinical Establishment Act. It is not a NABH requirement nowadays. Previously, we used to tell that zoning is part of the OT guidelines. So now it is part of the clinical establishment. So most of the statutory requirements are part of the government norms and not really part of the NABH requirements. We just ensure that all these government licenses are implemented in toto, and we just verify 4 or 5 licenses.
Okay, sir. So, Dipanshu, Kaushik, do we have more questions or comments, or else I'm ready to give vote of thanks?
I think this was an interesting session, and
Yeah, so
we have discussed a lot, I think.
yeah.
I think
So
Dipanshu should do a root cause analysis of his PowerPoint goof up and come back to us. That would be the first step towards implementing accurate standards.
I'll do that, sir. I'll personally message everyone regarding.
So we have the time is 10:15, and we have really had a very good discussion. So I would like to thank Dr. Nirmal Frederick sir for his an eye-opener talk, I should say, regarding NABH eye care standards. I would like to thank our panelists, Dr. Anandesh Pandey, Dr. Manoj Mathur, Dr. Prakash Marathe, and Dr. Sumit for their excellent comments. I would like to thank Dr. Dipanshu for moderating the session so very well. And we know that small things happens. So Dipanshu will be better prepared next time. And last but not the least, I would like to thank Numerotech for their technical support. And soon we'll be announcing our next session. And sorry for the delay.
I think next time even the speaker should be requested to bring first slide as his or her biodata. That will be the backup.
So we are sure that it won't happen. So next time, and we will just see to it.
Don't
that,
bother.
Yeah.
So don't bother too much about it. Thank you all. So it was a wonderful time with you, and very happy to be with you this evening.
It was a wonderful session. Everyone enjoyed it. Probably it is beneficial for all the
Very
youngsters.
informative, very informative
Yeah,
session. We should
all
say
of them.
that, and
All
I
of them.
will talk for us. Yeah.
Thank you, Auntie.
Thank you.
Thank you so much. Good night.
Thank you. Good night. Good night, everyone. Good night.
Good night.